So our last speaker for this symposium is Dr. Swathi Kiran. Dr. Kiran is a James and Cecilia Ying Professor of Neurorehabilitation in the Department of Speech and Hearing Sciences and the founding director of the Center for Brain Recovery at Boston University. She's also the co-founder and scientific advisor for Constant Therapy Health, a software platform for rehabilitation tools after brain injury. Her mission is to study neurological disorders in the brain while focusing on real outcomes for patients. And her talk today will be about using fNIRS to understand everyday interactions and discourse in post-stroke individuals with aphasia.
All right, thank you everybody for staying on for the second day and the last symposium. We have the panel presentation right after this, but it's kind of, it's sweet to come back a full circle because I'm going to talk about interaction today, and Joy started the conference off with interaction, so it's a nice way to come back. Before I get started, I should just get done with my disclosures. As I said, as Maria said, I'm an advisor for Constant Therapy. It's a company I co-founded, and I should probably get all my funding out of the way as well. All right, so we study individuals with post-stroke aphasia, and many of you probably know what this is, but if you don't, it is when someone has a stroke in the left hemisphere, predominantly processing language. It's an acquired language impairment. It affects about 30 to 40% of stroke survivors. There's about 180,000 new cases per year in the US alone. And what stroke does to someone is reduce their social participation as well as their overall quality of life. It's a long-term disability. Once somebody has a stroke, they don't, many of them have it for the rest of their lives. About 90% of people with aphasia remain aphasic even 1 year after their stroke. So I'm going to show you a video, hopefully the audio works, of someone who has had a stroke and is trying to communicate.
Yeah, whatever you see.
Oh, okay. I can't, you know.
Make it into sentences.
Brain, you know.
Try to.
I can see and hear, but
that's okay. Give it your best shot.
Connected my brain, you know.
So that's what I want you to try to do is look at this picture and tell me what you see.
Ragpole.
Okay.
No.
What else? What else do you see?
So here's somebody who can tell you that he knows what he wants to say, but the words don't come out through his mouth. And when asked to describe a picture, has a really hard time getting words out. He, in fact, only gets one word out. And so, you know, we're thinking, I'm sure you're thinking, and we're thinking, what's going on in his brain? He knows the words, but he can't communicate that. And that's really what we're trying to study in this population. So our understanding of language recovery, when somebody has a stroke, how much they recover, comes a lot from fMRI studies of mostly single word processing. So most fMRI studies require a person to go into the brain scan, lie down, and have them do these very simple tasks where they see a picture of something and they're supposed to name a word, and then there's a gap, and then there's a picture of something else, and they're supposed to say skip or not do anything. And surprisingly, these studies have been quite useful in our understanding of language recovery. And so this is sort of a summary of different studies that have looked at people with aphasia and essentially found that the language network, despite the stroke, essentially is the same network as what you would see in healthy adults. Many of our studies have contributed to this data set. So we're looking at the same hardware, except it's been damaged because of the stroke. Our own work has sort of taken this in really in the question, in the pursuit of recovery. So we do language aphasia therapy with these individuals. And in one of the studies that I just want to mention, we looked at 20 patients with aphasia who received a naming therapy, and we compared them to 10 adults who did not, 10 stroke aphasic adults who did not receive therapy. We had them do the same single word naming tasks inside the scanner. And what we did in that process first was we looked at a network, an abnormal network of regions that was abnormally low in patients with aphasia relative to controls. And we called this the abnormal connectome. And then these patients went on to receiving therapy, and some of them responded to the therapy and some of them did not respond to therapy. We also had a control group, as I said, that did not receive that intervention. And what we found was that patients who starting off with this abnormal connectome, patients who responded to therapy showed improvements in this connectome. And patients who did not respond to therapy showed decreases in this connectome. So this connectome is actually is amenable to change as a function of rehabilitation. As expected, the control participants who did not receive any aphasia therapy actually did not change in this reorganization, this reorganized network. So we do know a lot about how the brain can recover after a stroke based on fMRI. In fact, we have a theory for how this works based on fMRI in terms of language recovery. So after a person has a stroke, there's varying degrees of recovery that someone can show. And the goal is to get as close to a healthy adult as possible. And what we have found so far in other studies and our own studies is that people who respond to treatment are the ones that end up looking closer and closer to healthy adults. And that's because their brain network can reorganize in a way that looks closer to healthy adults. And the patients who do not respond to treatment are the ones that don't have that optimal reorganization of the network. So they remain abnormal even after being provided treatment. And so that's sort of our current understanding of recovery. But this is an fMRI. As I said, these are based on primarily single word processing tasks, one word at a time, mostly no production. It does not capture the natural aspects of language processing and production, and it certainly does not address the questions I just showed you in the patient's video where he's able to communicate something, but when it comes to single words, he's struggling. So it's really not getting at what we want to really study in this population. So we sort of have to pause or keep going, but take an approach to look at different tools, other tools, and in the talk that I'm going to present today, sort of going back to first principles, but now doing this with the goal of studying fNIRS as a tool to really understand naturalistic language processing. So I'm sort of pivoting to a slightly different direction here. Okay. All right. So today I'm going to talk about two experiments. They're really fresh off the press. We just finished doing this summer. The goal is to examine a more naturalistic language output using functional near-infrared spectroscopy. We're trying a new tool. We're still doing this in healthy adults and in individuals with post-stroke aphasia. And we're really trying to look at the neural mechanisms supporting discourse and how they are altered in individuals with brain damage. And the goal is to really get away from that single word processing that we've done in the past. I have to acknowledge that this work is really done by Emily Braun. It was her PhD thesis. She was supposed to be here and present, but she just took a job as an assistant tenure track professor. So I'm doing this on her behalf. And Miriam and David have been integral in the whole development of this project. So for those of you who don't know fNIRS, and there are a few people maybe in the virtual audience, because everybody in this room knows about this, we're looking at fNIRS, which uses near-infrared light to measure hemodynamic response and task-based cortical activation. So this is on the surface, and we're looking at specific brain regions. As has been said multiple times at this conference, there are some clear benefits to fNIRS over fMRI, but let me just point out two that are very relevant for us. One is it can be done sitting up in a clinical environment. We don't have to put our patients in the scanner, which is actually next door, but it still limits 50% of our participants to go inside the scanner. And second, which is related to the first, metal implants is not a contraindication. And again, most of our stroke survivors have some sort of metal implant or the other. So this is a huge avenue for us from a practical standpoint. To be fair, there have been quite a few studies in fNIRS. And in people with aphasia, they've looked at resting state, semantic feature verification, and confrontation naming. That's been our own work. As well as other tasks, including a couple of narrative tasks. But they're generally showing a lot of variability across individuals and tasks, while there might be a general pattern of greater HBO in the left frontotemporal regions. It's not clear exactly what's going on, but it leaves open the opportunity to do careful work looking at recovery in these individuals and more importantly, at various time points in their recovery. So that's what we're trying to do, but we're taking several steps back because we've made, we're starting almost from scratch with fNIRS. We know we want to look at the language network, but now we want to sort of place it in this larger context of language in the context of discourse and production. So this is a framework for discourse production, but let me just put it in some specific context. When we ask somebody to produce a sentence, like the rabbit is trying to get a carrot and the magician walks in, we are tapping into several things all at once. Of course, we're tapping into lexical retrieval, phonology, and syntax. That's what we think we're studying in specific words such as rabbit and magician. We're also looking at planning in pre-linguistic planning, such as utterance planning and the sequencing of words and the sentence semantics. But we're also looking at macro structure planning. So how does the person organize that sentence? What's the coherence in that whole passage they're trying to say? What's the gist and what's the structure? And if we're lucky, we might get some pragmatic components yet, but we haven't gotten that far. But this is sort of what we think we're tapping when we are asking people to produce long sentences and discourse. So again, going back to the drawing board here, we said, okay, we know what we're doing in fMRI tasks when we're tapping into the language network. Let's start with the same regions in fNIRS. So what you see here is what our typical probes look like. And in both the experiments I'll present, these are the probes we have identified. There are essentially 9 regions of interest, but they'll end up getting averaged afterwards. But we're looking at prefrontal, just left MFG, frontal regions, temporal regions, left parietal and bilateral parietal regions, and our control region here is the precentral gyrus. These probes are created in Atlas Viewer. We have 37 channels with 8 short separate detectors. This is what it looks like on a person. We 3D print the caps. And we take head measurements for each person to make sure that we are localizing the channel. But this is all, this is new stuff for us because we have people who've had a stroke. So I know this is, there's the fairly accepted processing stream for fNIRS data, but I want to point out a couple of things we are doing in addition. Because we have people with stroke and they don't produce things all the time. If you ask them to respond, they might just sit silently like I showed you in the video. So we have to manually exclude blocks with errors or no responses. Then we have to deal with the lesion, and the lesion happens to be in the left hemisphere. So for now, at least, we manually go back and turn off the channels where we have identified a lesion based on the MRI scan. It's something we're trying to get a bit more automated, but those are our big issues. And then once we've done that, we do follow the same process that everyone else does. We prune the channels, we transform the data, we correct for motion, and eventually we get the data we want to look for. Okay, then this is the data that we have collected so far. We have 2 experiments. In the first experiment, these are small studies because remember, we're just trying this out as a feasibility proof of concept set of studies. So we have young adults, we have age-matched controls to our patients with aphasia, who generally tend to be in the 60s, and so our older adults are in the same age range. And what I want to point out in our patients, there are 17 of them in this first experiment, is they're all chronic aphasic individuals. That's what you see in this time post-stroke here. But they're also not that severely aphasic. So what you see here in the Western Aphasia Battery, which is our measure of aphasia severity, the scores are pretty high. So an 82.8 is actually a mild aphasia. So they're generally performing, they're able to produce language. The BNT is a naming score, and the cognitive linguistic composite score is essentially their language and cognitive skills. These are generally mild scores, but they still struggle with communication and overall quality of life because it's affected their ability to interact in their society. So the task that I first want to describe is a computer-based story narrative. So these are 2 silent videos that people watch. They first watch a segment for 68 seconds. Then they get about 15 seconds to describe what they saw in the story. Then they get about 5 to 15. It's a jittered ISI baseline, so there's time for them to just come back, take a break. And then they watch the next segment for 68 seconds, and then they have 15 seconds to say what they saw. In the control condition, they're watching a silent video again, but now there's nothing, I mean, there's just like silent shapes morphing over time. So there's really nothing to watch there other than those evolving shapes. But that also they watch for 68 seconds and then 15 seconds to count from 1 to 15, then again, another video, and then count from 1 to 15. So here's an example of a video that they watch, and I'm going to play the video, the audios side by side for a person who is a healthy older adult and a patient with aphasia, and you can sort of see how people, do this task differently. So that's the video. Okay, and here's the first audio.
Okay, so there's a rabbit, and he's hungry, and he's trying to get a carrot from the desk. Meanwhile, a magician comes into the room, and he's trying to prep for his act, and the rabbit's more interested in just getting food.
Okay, and of course, here's a patient with aphasia.
Waiter and a rabbit were playing games.
So you can see there's a lot for us to unpack there in terms of what the patient is saying.
Okay, so
So the first thing we did when we looked at the results here is to compare the healthy adults, the older adults, as well as the patients with aphasia as a group. This is averaged across ROIs and averaged across time. So this is really just looking for a main effect of group differences, and we get one between the young and older adults. Not very interesting, in my opinion, but it's a good validation that we're actually getting group differences. But what we're really looking at is sort of the time course of activation, because this is the first time we're actually looking at time course of language production. In fMRI, we don't get to do that. So we're taking a close look at what we've got so far. So in the young neurotypical adults, we start to see a clear effect of the difference between the experimental condition, which is the summary that you just heard, versus the counting. And any box that's bolded is significant. So I'll go through these fairly quickly. Just to orient you, time is here. So that's the 15 second that they get to respond. And the line on the top is the summary, and then the one on the bottom is the counting. So in the young adults, we see a clear effect in left MFG, bilateral frontal, left temporal, and right precentral. We don't see any differences in some of the other ROIs. When we look at our age-matched older adults in the same sets of ROIs, we essentially see a difference across all the different regions we're looking at, whereas there's a clear effect a clear effect for summary versus counting across all these different regions. Now, in the stroke patients, what we see now is that we get a clear effect in left MFG, but we also get a clear effect in the left frontal and right frontal regions. We're also getting a nice response in the right temporal region and the right parietal, which we're kind of surprised. I'll get to that in a second. But in the left parietal, we actually get an opposite effect where there's more activation for counting relative to summary, and the other regions don't show any changes in activation. So the other thing that we are doing in this process is calculating a score of global coherence. So this is essentially taking what they said and giving it a numerical value. And here the idea is to calculate it in terms of gist versus content. So this person would get a score of 3.7 because they got some of that ideas across. As we expect, patients with aphasia are bad at this task, and they score poorly relative to the healthy controls. That's what we would expect. And these sort of scores correlate with their overall measures of severity. So the more severe they are, the worse they are at this task. But surprisingly, these measures, this particular measure, global coherence, does not yet correlate with the HBO at uncorrected. There's some correlations at uncorrected values. So I'm going to come back to this later on. But just to wrap the first experiment for you, we see activation in left precentral and right precentral for the young and healthy adults. Left parietal shows some slightly funky findings, but what we are really looking for are these activations in left MFG, left frontal, right frontal, and bilateral temporal. So these are the regions we were looking for, and we see them in the healthy adults, but to a certain extent in the patients as well. So in the next study, this is sort of a replication, but with a different task. We have a similar group, 15 to 16 patients. There's a bit of overlap in the patients as well. And again, we are really looking at mild aphasic patients, same profile. They're mild in their aphasia, but their disability is fairly remarkable here as well. And here the task is somewhat different, but it's requiring the similar kind of production. Here, we actually have them sit in front of an experimenter. The experimenter asks them a question, and then they have 15 seconds to respond to that question. And then there's a 10 to 15 second ISI gap, and then the experimenter asks them the next question, and they have 15 seconds to respond to that as well. And in the control condition, they hear a sentence, the sun is shining and the birds are out. And then they have to repeat that sentence 3 times over and over again. And then they hear the sentence again, and they have to repeat it 3 times again. So it's really just a repetition task that we're doing here. This is what it looks like, and this is really what we're going for, is that in a clinical situation, the patient and the clinician sit across each other, and they're going through this conversation. And just for an example, the question that I'm going to show you is, what do you like to do in your free time? And here's a healthy person.
A lot of people like to ski, ice skate, sled, make snowmen, snow caves.
Okay.
Lazy. Computer. Loaf.
Again, there's a lot.
Lazy.
Oh, sorry. There's a lot for us to unpack there in terms of the content as well as the structure of what they're saying. But again, going back at the group level, there are some clear differences in left frontal and right frontal between groups, especially if there's an age-related effect, but there's also a stroke difference for the right frontal. But again, going through quickly, this is what we're really looking at, because this is going to help us understand what's going on in the language processing part. I'm going to go through the results the exact same way, except now we're looking at a contrast between answering the question versus repeating the sentences 3 times. And anything that's significant is marked in a box. So in the young adults, we see this nice effect for bilateral frontal. And we also see this nice effect for temporal. And I just want to point out, Joy, you and I were talking about this yesterday, and the effects for the temporal are actually quite robust across both experiments. We also see a left parietal effect here, and everything else is not significant for the young adults. For the age-matched group, again, we see stronger effects, but some of these are actually negative, in the negative direction here, which is not something we were expecting. So I don't think we can really interpret any of that. But otherwise, we tend to see this difference between answer and repeat in the older adults, and then nothing else is significant. And then in the patients with aphasia, again, we see this clear effect. For some reason, the effects are not as strong, but there's a clear answer versus repeat contrast. Again, the effect is more robust in the temporal regions than it is in the frontal. And then we get this quite surprising effect where there's actually more activation for repeating versus answering. And I'm going to come back to that later on. Okay, so that's just to give you a snapshot of where things are going. I'll speed this along. We get some activation in bilateral parietal, which is a bit surprising. I'll come back to that. But our frontal activation and temporal activation is, again, robust, very robust in the stroke patients as well. What we are trying to do here is really see what we've got in the fNIRS experiments and then compare them to what we understand happens in the fMRI experiments with aphasia. So we're using a benchmark from a fMRI, knowing that it's not the perfect benchmark. But given that, this is what we're seeing so far. Compared to other groups, patients with aphasia tend to show a clear effect in MFG, which again, I wonder we think it's a cognitive thing. We'll see what's going on as they get better over time. But we also get bilateral frontal for the first experiment, not for the second. And we think this is sort of getting into the linguistic output, we thought we were tapping into the word production part, also into the pre-linguistic planning. So this is the sort of sentence formulation part, which they struggle with as well. As well as the microstructural planning, which is the global coherence score, although as I said, it didn't really correlate with the activation. We don't really know what we're getting into in terms of the pragmatics, but for so far, it seems like we're tapping into brain regions for the patients for these processes at least. The temporal activation is what was really interesting. We weren't expecting to get a strong response in the patients, so I think we're definitely tapping into the linguistic propositional and macrostructural planning, because fMRI studies have shown this as well. But I think what we might also be tapping into here is an auditory feedback of the spoken output, which we never had a chance to study in fMRI, whereas we're able to do that in real time here. Now, when we look at the precentral regions, this is actually our control, because we're having our patients produce things even in the control condition, and we get some, we actually get some results, but what's surprising is we get more activation for the control condition. And one of our theories is that maybe the control condition is actually harder for the patients because they have to produce this over and over again. And if you saw anything in the videos, they're struggling to produce anything. So just putting them in that situation where they have to produce things over and over again is actually more work for them. And by the same token, we saw slightly opposite results for the left, the bilateral parietal regions, only for the patients, not for the control, the age match and young controls. And again, I think this has to do something to do with their aphasia and how the word retrieval sentence production is so disrupted that it's actually more work for them to be doing the control condition than the experimental condition. So we've learned a lot in this process. I was going to say, we don't think that these bilateral parietal regions have anything to do with linguistic propositional output, because they seem to be focusing on, they seem to be tapping into something else for us. There's a lot of caveats and limitations. I mean, these are really exciting findings for us to sort of replicate everything we've done in fMRI and more. However, by the time we take out lesioned ROIs, because we had to do that manually in some cases, we don't actually have much data in specific ROIs, and this is something that we have to figure out how to do so we're not losing channels en masse, which is something that's happening right now. We were very careful in picking left pre-central as our control ROI, but as I showed you, in some cases, we actually see more activation there. This is a real buzzkill for me right now, is the individual differences, which we're really hoping would show this correlation with the degree of activation in the ROIs. And as such, they don't correlate, but we're starting to think that maybe it's not just a combination of coherence, it's also a combination of coherence and severity and naming score. So we'll be working a lot more on that. And even though fNIRS is great relative to fMRI, there's still jaw-related motion artifacts and physiological noise. So everything that Alex was talking about yesterday in terms of things we need to consider, it's 3 times the problem for us with our stroke patients, and something we have to clean up. Despite that, where we think we're going next is to really look at this as a measure of treatment. That's why we're really trying to carefully document what we see in these patients relative to controls, because we think that once we can identify what is a baseline profile for stroke patients, we can actually use that as a measure of change. So this is a computerized treatment version that's very popularly used for people with aphasia. They sort of walk through sentences with the clinician. Sometimes they say it alone, sometimes they say it with this virtual clinician, and sometimes they have to say it by themselves. And as they get better, they're supposed to be more and more independent in their production. And our goal is to put the cap on these patients as they're going through the steps, step by step, and see if we see, first of all, reduction in this activation, because that's what we would predict. As patients get better with performance, we should see a decrease in activation in at least MFG. The other thing that we really want to look at is, again, we expect some patients to respond and some patients do not respond in treatment. And so we would like to look at changes in functional connectivity in the fNIRS nodes of change, nodes of ROIs in terms of what changes as a function of intervention. The other thing that we've started doing also is to look at continuous brain monitoring. And what I mean by that is, I think a lot of us have seen the study that came out a couple of years ago that essentially showed from the UK Biobank data that when you looked at behavioral measures such as fluid intelligence and other such measures, essentially this very large data set included people who went on to, some of whom went on to developing dementia, and found that measures such as fluid intelligence changes could be detected 10 years prior to the diagnosis. So these are changes that are happening in the brain much before the disease sets in, and this can be used to aid diagnosis. So we think that we can actually start doing this now in patients both with neurological disease such as stroke and dementia, and compare them with really the goal of asking, does the signal of somebody who looks healthy and going about life look different from someone who is developing a neurological disease or undergoing a neurological disease? And I just want to point out that we can do this both in the case of somebody who's about to have a stroke because they have these sudden changes in behavior, versus somebody who is going to develop dementia and the changes are far more gradual over time. But for this, we have to collect a lot of data, continuous data from our stroke patients and our dementia patients. So that's one thing we would like to do. The other thing we would like to do is to use that large amounts of data to see what natural variation in the signal is versus big spikes or gradual declines, and use that to predict whether somebody is actually going to be at risk for developing mild cognitive impairment or dementia versus somebody who's fine. And on the flip side, use that to predict which patients with aphasia we think will recover from the intervention we're going to provide them versus which patients won't change as well. So this is really where we're going. And our first approach was what I was showing you today. And again, I have to thank the team that does this work. Many of them are in this room who are also helping with the conference today. But thank you very much for your attention and your time. Thanks.
Thank you very much for your impressive talk. You have to deal with a wide variety of aphasic patients. There should be a kind of the symptom differences in aphasia. How did you tackle these problems? And was there any relationship between the severity of aphasia?
Yeah, great question. And that's, I'm glad you asked that. Well, this is our first time doing this, fNIRS with production in people with aphasia. So to a certain extent, we only included people who are able to produce at least some level of words in their sample. So if they were completely nonverbal, we could not do this experiment with them. So that itself takes out the lower level of patients who are very severe in aphasia. So that's one thing. Now, between the types of aphasia, I don't think it actually makes a difference because we're having them produce these sentences, and the way they're being scored on it depends on what type of aphasia they have, but they're not getting penalized as much in the global coherence score. It gives them some points. However, I'm sure it makes a difference depending on which brain regions are more active or less active, depending on the type of aphasia and where the lesion is. But that's the data we have to unpack. With 15 people, it's very hard to unpack that sort of subtle effects. But at least for the next set of studies, I think we'll know what we're looking for there. There was a second question you said about...
Well, then were there any differences, I mean,
in terms of severity.
Severity of aphasia, I mean, the relationship between the cortical activation and...
Yeah, that's what I'm sort of disappointed that we have. With 15 people, we didn't find this clear relationship where the more higher your language score, the more the activation or the less the activation. I would be fine with either of those correlations in MFG versus temporal, but we haven't seen anything yet. But I think we're looking at two cores of measure, which is global coherence score. I think we have to look at coherence plus aphasia severity, which we haven't quite done yet. We wanted to look at what overall production was like, but I think that was too big a net. I think we have to make it more fine grained, but good question.
Thank you very much.
There's a question from online. It says, it was a fantastic talk, thanks. In slide 14, what is the reason you put the exact 68 seconds for watching the narrative video?
Oh, wow. Why 68 and not more than that? I think there was... so Erin has the answer because she was involved in splitting up the clips. The whole video divides into 4 segments of 68 seconds. And so that's all, that was the only reason. Great. Joy?
Great talk and amazing study. I'm so excited by your results and so your preliminary findings that you're actually using interpersonal interaction as part of the therapy. And I think that there's huge potential for understanding the basic mechanisms. And I'm wondering if in the future that you might be considering looking at, say, the effect of eye-to-eye contact,
Yeah.
or the effect of facial recognition or facial classification
Yeah.
in as a mechanism for improvement of aphasia in your future studies.
Absolutely, Joy, you bring up a really good point. And actually Emily's first study, she had 3 studies in her dissertation. In the first study, we did the same question and answer, but the patient was talking to a computer. And the results weren't that, I mean, it was also the way we analyzed the data, but they were not as robust as the actual live interlocutor, which we're really happy about, because that's where we think we want the therapy to, and the therapy and the fNIRS to really intersect, is we want to be able to do this in the clinic when they come in and they're having that conversation with the clinician. I think there's an easy way for us to do it asynchronously, where they're doing the therapy by themselves, we're measuring brain function. There's a way for us to do that at home. We know exactly how to do it. But then there's also this in-person component with the clinician. And that's the kind of interaction we're really interested in. And actually, I would take it a step further to what you were talking about yesterday. That's where I think we'll see things like empathy, like compassion, like, frustration, because when they're talking to the clinician, they're expressing their frustration about why they can't say something, just like the video I showed you. So it's language plus other things. And we're trying to just take out the effect of language first so that we can look at those other things afterwards.
Yeah, and I think this is just an amazing future direction, set of hypotheses to test, also getting at fundamental mechanisms. I had one other question that's on a much smaller level, less far-reaching, but I noticed that you were using the oxyhemoglobin signal primarily, or perhaps exclusively. Is there a reason why you have not used the deoxyhemoglobin
No, it's
signal?
a great question. I just didn't present the results today because there was a lot.
But you actually have been. Are they similar?
In many cases, they are similar. In some cases, they're quite different. And that's what Emily was looking at very carefully. And the ultimate implications of our data is when they both align. When they don't align, we've been careful to not draw too many conclusions about that.
Yeah, I was just hearkening back to Felix Golkman's sort of really foundational work in this regard, and that we've also been inspired by his work in doing the talking experiments. And because of his findings and our replication of those that show the oxygen changes during talking, that we have for any of our talking experiments have relied exclusively on the deoxyhemoglobin signal for that reason.
That's a great point. I mean, all the slides are there. I just chose to show the oxygenated ones for this, but that's
just a cautionary
note.
note.
Absolutely. No, and we're very careful about only trying to interpret when they both align. Yeah.
Hi, Dr. Kiran. Great talk again. I just have 2 questions regarding aphasia. So my first question is there a gap between comprehension and repeating what's comprehended? Or is it that the comprehension in itself is incorrect and hence they're not able to repeat whatever the input is? That's
a great question. It's depending on the type of aphasia, it could be one or both. So there's types of aphasia like Wernicke's aphasia where they don't understand what's being told to them. So you can say the sun is out and they'll hear it as banana. And that's because they have a damage to the temporal cortex. There are other types of aphasia where they can understand a lot of what's being said to them, but the connecting fibers between Wernicke's area and Broca's area and all the other pathways in between are disconnected. So while they understand little or most of what's being said to them, they cannot formulate what needs to be said in order to repeat. And that's a certain kind of aphasia. I am pretty sure we had some of them in this study, but that's a next level question and actually Erin, who's here, is trying to look at that. How much of what was being said to them they understood, and how much of what they actually planned they said. That's like the next level of trying to look at this data, because that's we do have to separate those things out.
I see. Thank you so much. And my second question, I'm sorry. My second question will be, there's a sort of going off of the tangent. There's a study from Berkeley or Stanford. I don't remember exactly. They used recurrent neural nets to help patients who are paralyzed formulate their speech. I saw your data sets, and when you said that there's some differences which are seen 10 years before the actual onset of the disease, I was wondering if recurrent neural nets can be used as an assistive device or supporting mechanism for patients with aphasia to formulate their or express their comprehension.
So that's a great question, but it's a very complicated answer, because all of the studies so far that have used, you're talking about the BCI studies at UCSF, yeah. All of those studies that are showing that decoding of the neural network are happening in patients who have subcortical lesions. When you have a cortical lesion, then they're not studying post-stroke aphasia in the pure form, because that part of the brain cannot do that encoding effectively. So I'm not sure we have a direct parallel yet, although I've talked to Eddie Chang and all the other folks who are doing this. I think we're a bit of ways, because we're dealing with damaged cortex, whereas they're dealing with that cortex that's not damaged. So that's a good, that's sort of the caveat for, we can't do that. However, I think what I learned from this meeting is, especially Bettina's talk yesterday, is that I think you can use fNIRS to do some of that imagery, to then use it to decode, to then build models off it. And I think that, and I'm telling this to my group as well, there is work that is really exciting that's coming out where people are studying internal speech in people with aphasia. And it goes back to the video I showed where he's saying, I know what I want to say. And so there are people who are trying to study how well people with aphasia who can't speak can actually internalize that. So if we can go and capitalize on that, so what are they thinking? And use that in terms of imagery and decode it, I think we could then circle the loop with assistive devices. That seems to be an easier path for us to take than doing the BCI stuff.
All right, perfect. Thank you so much.
Yeah.
So Joy was asking about eye-to-eye contact and facial recognition, and could you use that in your study? I thought she was going to ask about brain synchrony.
Yeah.
So could you imagine using brain synchrony between the clinician and the patient? And what would you do with that?
I just was telling these folks this morning that that's been the most inspiring thing about this conference for me, is for us to talk about how to do that. I have to be honest that I think we were only thinking about studying the patient's brain and the therapy. We never actually thought, let's also put the cap on the clinician and see what's happening there. And until I saw your slides today, I was like, oh my God, why are we not doing that? We should look at the clinician's brain and how that's interacting with the patient, and see if there's sort of a recovery that's happening in the brain of the patient, plus the social interaction piece. I mean, it's like 10 PhD dissertations just lined up right there, but thanks for the ideas. Those are great ideas.
I wish I would have asked that question. Good, thanks for the help. I just want to just a comment on that we'll need full brain coverage.
Yes.
Because the synchrony, at least that we've observed between both the clinician and the patient, or just the two interlocutors, is back of the brain and dorsal.
Great.
And our hypothesis is, and we're working on this, and I don't know if this is true or not, but the cross-brain synchrony during live interaction is largely due to eye-to-eye contact. And the measurements that we have on this suggest that we need to be looking at dorsal stream activity, particularly dorsal stream and lateral stream, but posterior aspects. And so this is sort of a plea to the biomedical engineers here to get back there, give us full brain coverage.
Yeah, that's a fabulous comment. And I think that's exactly, as you saw yesterday, David and his team are already trying to develop, getting the whole brain cap ready. But for us, it gives us a reason to look beyond language network, because that's all we're used to looking at, and we don't know where else to look. But this discussion and other studies that come out will tell us where else we need to be looking in the brain. Thank you so much for your attention and for the whole conference. It's been, So when we started this conference, we said that one of the, the Chen Institute was very generous in their funding for this meeting. And one of the things they asked us to do was to bring scholars, young scholars from all over the world who are interested in this topic and would be willing to articulate what they've learned from the conference, because they're really, they're really interested in in exciting the next generation of scientists. So we're really happy to have the funding to offer, and we're really thankful that you've all agreed to do this as part of your coming to this conference. Hopefully it was a great experience, and this is sort of a culmination of a conversation you would have had anywhere in the airport or something, but you're doing it now with all of us. So I think you have a leader, Ike. You're the leader, and I'll hand it over to you.
I will do my best. So first of all, I would like to convey our sincere thanks for having us here and for supporting us to get here. And we thought that we start off by giving, again, a very short introduction of who we actually are and what we are working on. And then we were given 2 questions to get that panel started. So with the introductions, so I'm Eike Midel. I'm working in Alex Group as a postdoc, and doing there mainly software development and method development for fNIRS research, for multimodal fNIRS research.
Hello, I'm Katarzyna Wisiecka, Kasia Wisiecka. I'm working at the University of Waterloo right now with Andrew Duchowski, also as a part of the team of WISA. We are investigating aviation and pilots, but basically I'm from Poland, from SWPS University, and investigating synchronization between participants during collaboration. And I'm just finishing PhD, so I'm very excited.
My name is Michelle Goodrick. I am from the US, but I am now living and studying in Mexico and San Luis Potosí, and looking specifically at how the work of yoga asana, so physical posture, affects brain activity. Eventually, hopefully, we can see also how it affects symptoms of depression and anxiety. So again, this idea of trying to get in through the body to affect the brain rather than vice versa.
Hello, my name is Andrew Hagan. I'm from Colorado State University, and I'm a PhD student there. A lot of my work focuses on gait adaptation and motor learning, specifically in people with MS, and looking at new novel applications of imaging along with that.
Hello, everyone. My name is Ito Polo, and I'm from Drexel University, Philadelphia, Pennsylvania, and I work on assessment of human social behavior in terms of social cognition and social bonding using in naturalistic human-robot interactions using fNIRS and also oxytocin measurements. So, yeah.
Hello, everyone. My name is Kevin Ramirez, also from Drexel University, working under Dr. Hassan Ayaz, who gave a talk earlier. And apart from all of those projects that we're involved, I am right now trying to assess the impact of the environment using multimodal wearable devices and sensors.
Hi, my name is Adrian Curtin. I'm a postdoctoral fellow also at Drexel University. Right now, my research is focused on kind of multimodal, naturalistic, neuroergonomic assessments of things. So this will be covering things like cooperative team play, as well as naturalistic navigation, among other things.
I think you just pass that back.
Yeah, well, you already have. Yeah.
Okay, so the first question.
Is it on? Okay, now it's on. My name is Condell Eastman. I'm a PhD student at RPI, and I work on using fNIRS for surgical skill assessment.
Okay, sorry. The 2 questions which we were asked. The first one is, in your opinion, what does the future of neuroscience in the everyday world look like? For example, novel techniques, applications, innovations, and that in your specific subfield. So if I may go first. I think it's clear that as soon as you leave the controlled environment of the laboratory, things become more complicated. And adds already to a complicated situation where you have that fNIRS signal with its many compounds which need to be understood. And I think what we will see is that we will need much more modeling of the fNIRS signal, understanding what the components are and how we can describe them. Because as soon as you go into the uncontrolled environments, we should be sure that we understand that signal, and modeling will help.
I totally agree on you on that. So like whenever I research like fNIRS papers and like also all the posters and all the research done here, like in the conference, like all I'm seeing is there are like so many ways to interpret and deal with fNIRS data. There is this ICA, PCA, CBSI, like a lot of like filtering, adaptive filtering, or like there are like so many options and so many things that we can go. So like I think this has pros and cons. Like the pros is like the world is your oyster. So you can interpret your data however you like, anytime you like. But like I think there's some cons as well, because there is no clear and concise way of how to deal with how to interpret with fNIRS data. It gets sometimes confusing for others as well. And I think as a fNIRS community, we need to discuss on like which ways are much more advantageous, or like what to do, how to deal with the fNIRS data, not only for us, but only for the others that want to use fNIRS as well.
Kind of bouncing off of that, I guess I have a question for anybody here who does do studies with fNIRS. Do you guys think that as the field progresses, we will start to see something more uniform, like what you see with EEG in terms of processing? Or do you think that I'm sorry, I forgot your name. Yeah, so as you mentioned, that we'll see, or that the benefits of this sort of varied approach to processing the data and interpreting the data will continue to have its benefits and continue to grow in that way?
Sorry, I kind of lost what was the question? Sorry about that.
So do you think that as the field of fNIRS continues to mature, do you think we'll see more uniformity in the way that people process the data? Or do you think that as we continue to see more algorithms come out and more development of these algorithms?
I think in terms of like processing data, like there will be, I should say, there's definitely like more in terms of like very variability we will see, but also like in terms of how should I say this? I'm kind of lost in words. Sorry about that. So like I think it would be we should strike a balance between that uniformity and variability. You know, like
sorry, I have a pickup microphone, so to kind of take that in a sort of different direction. EEG's like trajectory over time has been sort of one of working with one particular signal, and then going from graph paper, and a lot of the stuff is actually just still inspired. The analysis is still inspired by having to have everything plotted on paper and then work off of that. The future of fNIRS and the future of neuroimaging in general, I think, is much more ad hoc and much more of a data aggregation problem. In the past, I think a lot of things were just trying to pick out specific repeatable trends in something, like looking for like the P300 and like being able to see like alpha waves, because you can easily do that with like some RC circuits, and you can measure it out. But when you come in for like point clouds and all sorts of other things for like motion capture data that can be fused with subjects walking around that can be fused with, the sounds that are coming in from different places. And then what all those things might mean to a specific signal that is, informed and is adaptive. It's more than just seeing a generalized average pattern in response to something, and it becomes more of how is this signal being generated by the participant. So I think that it's going to be a very different world in 10, 20 years than even we can imagine right now. But a lot of it will still be shaped by the things that we're doing at the moment.
I think sort of similar to that same point, there's a lot of advantages to having a lot of flexibility in how we want to process, but in general in science, we're having some reproducibility issues. And I think that getting to a point where there's some things that are not standardized maybe, but are more universal would really help with reproducibility of fNIRS data. And I think that's one thing that is definitely needed in order to, take one study to actually create changes in like a participant's life. So I think that's something that hopefully in some years we'll have something that's more, and I think a lot of work that people are doing here is contributing to that as well too.
I'm going off filters and going into the body. I think the future of neuroscience, hopefully with fNIRS, we can start to bring the body back into neuroscience, into psychology, and start to see, okay, well, what can we do with the physical form to actually start to affect changes in the brain and actually measure it? Because that's been the thing we haven't been able to do with an fMRI, very difficult with EEGs as well. So with the technology of fNIRS, there's just an amazing field that can start to open into seeing how physical form actually starts to affect the way the brain works.
Yes, so maybe I'm in this path of thinking. I'm a psychologist, so I'm thinking about this neuroscience as a part, of course, of my work with also the patients. And I'm during finishing school of psychotherapy. And this last talk was really amazed me. And I was thinking since yesterday about this kind of studies, like what's going on between patients and therapists, because I used to hear from patients that they don't want actually to work with robots or have any chips in their brains. They're looking for help, conversation with a human being. So what's going on with this process of recovering from any kind of disease? And because as I saw here, we are looking for some developments based on exogenous processes, and recovery is more endogenous. And I'm not feeling like we know exactly what is happening during this recovery process from depression, of course. As yesterday we talked that we don't even know what's the neurobasic general of this depression. So thinking about completely changing life in neuroscience, as you said, where that everything will be changed. I'm not sure about that. I think maybe taking a step back somewhere to the human, to the body, and to natural processes that are not maybe discovered yet enough is good enough. Yeah, this is only my perspective from this psychological point of view. But yeah, of course, technology and so on. I spent right now 6 years working with IT people and computers and so on. So I know that it's a need for that, but there's something that I miss. And I think there's supposed to be some kind of bridge between this what we know right now, especially in this therapeutic path, and technology that would like to, change everything in 1 second in the brain. Yeah, so.
So yeah, I think what we can do, again, it's this bridge factor of, if we can use the technology of fNIRS, we can start to really see, well, what's the most effective way to move, or the most effective way to maybe talk to your patient, right? Like even just using the idea of gaze, like what is the most effective treatment? And so I think that there is a wonderful union that can happen between what is human and what is technology to be able to get the most effective way to heal, I guess you could say.
Sort of directly off of that too, I'm thinking about rehabilitation. A lot of rehabilitation is, learning new patterns or learning how to adjust your old patterns. And I think part of that is going to be looking at neuroeconomics, right? Like how can we use specifically with something like MS in my case, which is very widespread in terms of its symptoms and where the actual lesions are. How can we better determine who's going to be a responder to this therapy versus that therapy? And how can we also use neuroeconomics to just figure out what's the best learning conditions, how much should we push them, and things like that. And I think those will just kind of fine tune rehabilitation and make it more individualized, which I think is really, really important.
I think another point where I would like to see like the neuro engineering in the real world as like, the size of the sensors, right? So like, for example, in like 70s, 80s, we had like heart monitors that is the size of the stand. Now, like we are just wearing on our watches, like in our daily lives. And I wonder to myself, like, why not for brain sensors? Like we can take our app and like measure our heart rate, measure our blood flow, blood pressure. So like we can do the same thing for the brain sensors so that we can have the more user accessibility. Like, for example, like right now we have fNIRS experiments, right? And like they wear cap over cap and like headband, maybe like we can like in the future those caps get smaller and like maybe we can implement it in the people's daily lives.
I think in that sense, it's about, so what we're trying to see is to study the brain body in human, basically in everyday settings, right? So that means trying to see that in a routine perspective. What does you do usually at home or something? So as you said, the convergence of technology with software, trying to like converge those, I think that would be like a great thing that I would like to see in the future, bringing all of those tools into routines, into what people do, and incentivize the humans to like try to really use these tools, these technologies every day, trying to assess. Because for me, it's like, yeah, I would have like, I don't know, at home, maybe fNIRS tools, but why would I use it? Me as like a regular individual, maybe I'm not incentivized like to really wear it every day or like carry it on. So I think it should be something that a technology that is more less, even though it's non-invasive, even less invasive.
I had one comparison with how people kind of view the future, and sort of coming from the book Fahrenheit 451. There's a whole thing where everybody has TV walls. The TVs are the size of walls, and then that's how they envisioned. Ray Bradbury envisioned the future at that time, and cars were just faster and going 200 miles down the road, and so you just get nailed if you just like walked half a way across the street because you couldn't even see them coming. In his world, and that idea where the technology kind of just gets larger and larger. Is sort of it's an extrapolation of a trend. So you see things and you think, okay, well, everything's just going to get bigger. And we do have TVs that, are the size of walls, but most people watch their TV, a lot of times on their phones or their laptop or something like this, because, well, frankly, having a living room is increasingly a luxury with rent. But, the world is just very, very different. And even if you think about how you think about the future, you still tend to follow these extrapolations. So we think of like, okay, well, what is the future fNIRS system going to be? And the answer is like the same way we talk about the next study you're going to do. And you're like, oh, next time we'll have more subjects and, more channels and faster sampling speed and, you know, whatever. And some of those things will come true, but it's also that the future is more of less. So like what you can do with a higher like concentration on a smaller thing that's more lightweight, because you have battery considerations, you have application considerations, you have cost considerations. And so if you want to end up with something like a Fitbit study where you have 200 to 1 million participants, right? What incentivizes people to wear those things, to walk around? And and of course now with like a Apple Watch and everything like this, we have a ton of you know, real practical benefits that come around from having even one semi-optical, semi-electric system strapped to your arm. So EKG, like a heart rate fibrillation, and even possibly like non-invasive glucose monitoring for those same sorts of things. So what is the future for fNIRS in the brain? Because we don't, there's really only two typical, I'm gonna say interfaces that we use on our heads from a day-to-day thing, and that we're used to. People don't like to wear hats as much indoors as maybe was common in the 20s, but no one here is actually wearing a hat, headscarves excluded. But most people here have glasses and everyone here has used headphones or earbuds or something like this. So I kind of see that direction kind of being the space in which we start to see neural creep, like where actually the technology would come and become involved, because it's going to be, we want it to function as like a new limb that we're just exploring, but still exists within our own space. And I think at least for the future, that's where I see technology going.
Can I ask a question?
Yeah.
These are great ideas, but I hope you realize you're the ones doing all this work in the future. So I wonder if you're excited about these ideas. I think that's really fascinating because you know, what does technology look like when it's miniaturized and easy to use? Are you folks excited about the questions you're asking, and what do you see as an opportunity and a challenge? Sorry, that's a takeoff from what you're asking them. But these are great ideas.
Give a follow-up to that first.
Well, we can ask ChatGPT why we should all be scared. There's some things that are very exciting about it, and it's always like, you know, there's some things that trends towards dystopian, and there's other things that, you know, trends towards like utopian sorts of things. I think engineers are always optimists in a sense, because you always think you can fix things, even like while the entire thing is sinking. It's like, no, just a little bit more here, and then it will work.
Just a little more duct tape.
Exactly, more duct tape. And so I am inclined towards an optimistic future, and trying to make that happen. And I think that's kind of the mentality I'd like to approach it with. But you know, in reality, there's plenty of Black Mirror episodes out there to watch.
Yeah, the Black Mirror episodes. I think that is why we have to have that union between what is the technology aspect of it and the human aspect of it. Why are we doing what we're doing? Just always keep that in mind. Is it just because, well, we want to have like a cooler contraption that we can stick on our forehead or in our ears? Or is it because we really want to actually improve our existence as human beings? So I think that that's something we have to constantly kind of keep in mind to avoid the Black Mirror episodes. So, but that's also what's really interesting about fNIRS is that it seems like it's this wonderful bridge between what is this amazing world of engineering, which I'm not an engineer. I'm so glad that there are those who have that amazing skill to be able to do that. So then those of us who are more into the psychological aspect of it, we can say, okay, how can we use this with our human population? How can we use this to make life better? And yes, I'm very excited about being able to do that.
I would say one of the biggest challenges in my perspective is going to be collaboration in general. I think fNIRS is great because even in this room, there's a lot of interdisciplinary work going on, but I think to actually develop the things to make our human experience better, it's going to take a lot of different combinations of psychiatry, engineering, and all these other aspects of performance as well to actually make these changes. So I think that's one thing, and you could say this about science or anything that we've said in general this week about collaboration being really important, especially in this field. So I think that's probably our biggest challenge, and I think the greatest progress will probably come when we get better at that.
Okay, so answering again the question, yeah, I think I am excited, try to work, try to close the gaps that we still don't know. There are many challenges, so yeah, why not try and fix them? As you said, let's be optimistic. So let's reach for the stars, maybe one day. But in that sense, as people here has been saying, I think collaboration is crucial, and I think that's why we have these type of conferences, trying to see what's going out there, getting feedback from the community, and build upon that. There are things that maybe one laboratory doesn't know, or this other field like psychiatry or psychology. These things, all these fields can merge, neuroergonomics, and putting all of those into a perspective, into like one side, one vision, can really narrow those gaps that I mentioned. So it's all about being open. I know that in research field, everybody's just like, okay, I don't want to share too much because, you know, I don't want to somebody get to steal my idea and publish faster than me or something. But I think we should always be open for a discussion, be open to get new ideas and put ourselves out there. So and get feedback from the community. So yeah, why not? Yeah.
I think that kind of. Oh, okay. I think like that kind of brings in the question of the like what we learned from the conference. What was the impact? I think like it's very exciting to see like so many different like researchers from so many different areas like worldwide working like converging on this same like converging on this one thing, which is like the neuroengineering in the real world. And that is exciting because you get to see like all the researches, like all the, as I said, like different analysis, different perspectives on how to interpret and analyze the fNIRS signals, and like all the different perspectives. So this conference has been like really impactful on my part. Like I don't know who the other part is, but yeah.
You made exactly the transition to the second question that I also wanted to make. So the question was, what have you learned at the conference that will inform and impact your own work? And about the motivation, we have seen today applications. We have seen them in the therapeutic and diagnostic area where there is obviously a need and where neuroimaging in the everyday world could help. So that motivates, and it motivates to that technique and build tools for it. And this is what I mainly take away from that conference, is a strong motivation to build these tools. Also on a smaller note, what we have seen is, for example, in the neuromotor therapy, there are these feedback loops where we have neuroimaging techniques to measure something, which on the spot have to feed back into the application, and that real-time requirement that I would previously more have associated with BCI applications happens also there. So that I hadn't on the screen so far.
Okay, so first maybe I will answer the question, am I excited about the future? Yes, I am, especially after this conference. Because it's some kind of turning point in my road, in my way. I felt like maybe I would just focus on working with people and, you know, say goodbye to the research. But yeah, I have right now so many concerns, so many questions, and my curiosity just uplifted me a little bit here. And I'm very grateful that I can be surrounded like the authors that I'm citing all the time, especially in the field of collaboration. I started this subject and my dissertation 1 year before the pandemic, and I didn't know that this subject of collaboration, remote and face-to-face collaboration, will be so right now like on the top. So when I'm here and listen to your amazing studies using fMRI, yeah, this is something what I was always dreaming of, but I didn't have possibility to use this kind of equipment. But using eye tracking actually enabled me to see the processes that I'm actually interested in. And this is maybe something what is connected that we are talking about yesterday, about what we need actually to answer our questions. So basically, I realized, actually my supervisor realized, Krzysztof Kreis, that you don't need like EEG, fMRI, you have your questions about joint attention, about synchronization. You can just take what you have and do it. And, you know, I am really happy that I did it. But of course, right now I would like to use EEG and everything. So I'll go back to these articles for sure. Yeah, and what will I gain to my practice right now? Many things. I was thinking like half of a night tonight, last night, about this, what we can do with this information, what I can do, and for sure it will change something. And I didn't realize that when I will be here, I will gain so much information in my subject. Yeah. Okay, anyone?
I guess. Yeah. Anybody else? I guess so.
I mean, I think this is a particularly good crowd for the fNIRS community because we have a huge, had a huge diversity of perspectives. You know, maybe underrepresented here, but there's a lot of people here to whom fNIRS is a technology, something to be improved and refined and, you know, made better or cheaper or higher quality or however. There's the people to whom fNIRS is a signal of one among many, and that signal can be applied to different purposes and has as much value as the information that the signal carries. And there's people to whom fNIRS is a tool to be used for clinical aspects or for something to improve upon something else. For instance, changing the way that we view education or changing the way that we you know, view training and also therapy. So all of these different perspectives kind of give a more, you know, integrated view of what the technology is, both as a platform and as a and you know, as a future neural technology out there. So I think that this has been like nice to view all the little different sides from everybody here.
So as far as anything in particular that I think I gained or learned from this conference, so for me, one of the main reasons that I came here was to see, because I knew that a lot of the people here are leaders in the field in terms of processing and interpreting fNIRS data. And for me, based on my contributions to the conversation, I guess you can probably guess that I'm more on the data processing side. But I just wanted to see not only what people were doing with fNIRS, but I was pretty pleasantly surprised to see that there were a lot of people here who were also doing stuff with EEG or gaze data and trying to figure out how to integrate that with fNIRS, because this is something that our group has been doing for a couple of years now. We've been collecting all this data and we've been having all these discussions and attempts at how to integrate this, like how do we fuse EEG with fNIRS, with gaze, with video data to get the most out of it. And seeing some of the discussions here and seeing how, seeing who, like which labs have done what is something that I found pretty valuable. And I definitely have a lot that I'll be looking into after this conference based on that.
Yes, that's me. Oh, sorry. Go ahead. Go ahead.
Yeah, there is this like one of the I think advantages of this like joining this conference was actually discussions about the multimodality, like how we can utilize like not only fNIRS but also other measures such as like ED, like electrodermal activity, heart rate, or like eye tracking, and like it's fascinating to see all of these experts from like different areas converge into this one conference to share and improve, share their thoughts, their perspectives, and improve. So yeah.
Okay, so what have I learned? That it's amazing. There are so many applications with various forms. I had no idea about the eye gazing technology until I came here, and I was like, oh, that's really interesting. And then of course my brain's like, oh, how can that be applied? And looking as well at just the EEG and the fMRI and just basically all of these different techniques, how they're applied differently, their strengths, their weaknesses. And yeah, again, just being like, okay, well, this is fascinating. How can we start to apply this to the human being? And there's just a whole realm of possibilities, and my brain has been just going 1,000 miles per hour thinking about all of those different options. So we'll see what happens in the future.
Yeah. So I think what I can take from this conference as a whole was every presenter and every person that I saw in the posters had a lot of passion of what they do. They show that this like excitement when they talk about it. And I like really feel it. Like from those conversations, everybody's just like, yeah, this is new and this is the next step. And then let's do this and do that. And I'm like, wow, I want to be like that. Like hopefully like getting there one day. And just like a mentor said, like if you are in a room and you feel like you're the smartest, maybe you're in the wrong room. And here is like, I feel not the smartest at all. So I think we should strive to get that from each one of the individuals here, really learn and really get passionate about what you do, because it's really like life-changing basically. So yeah, that's my main take.
Which are nice concluding words, I would say. But if someone from the audience wants to chime in.
I had a question actually related to the first half of the discussion, or the first question that was asked. Keeping in mind, if we want to bring this to the everyday world, then as early as possible, having all the stakeholders' opinions in mind would include, I guess, an everyday user, as well as, it seems like for a lot of us, clinicians. So I think clinicians are included in the studies quite a bit, and everyday people as subjects. But I think that there's more conversation that could be had. Just at the top of my mind, I realized maybe that's something that should be happening. So I'm wondering if you think the same thing, and how that should go about, or even marketing fNIRS. I know there's a lot of different systems commercially available. Yeah, what thoughts, if any, do you have on making sure end users are included as early as possible to make everyday use implementable?
I guess one thing I would say there is that there's, I guess, two types of end users: the people who might use fNIRS for themselves, and the people who might use fNIRS essentially on other people. So like a clinician who is recording somebody for their benefit, for therapy, this kind of thing. They're not really, they are sort of an end user, but like, you know, when you go to the doctor's office, when they take out their stethoscope, you're not really using the stethoscope. They are. And then for individuals who are going to like sit at home potentially with this thing, or whatever purpose it might include, those end users would be more self-motivated. So the reasons that they would choose these things would be for whatever specific benefit that might come with it. So, you know, if you have your watch, maybe it's so you can, you know, track your workouts, or if you, you know, have an iPhone, it's because you want to communicate or be in touch with the world. And so whatever that thing that is going to drive adoption of any technology, in a sense, it has to have the end user in mind, in a sense, because otherwise they're just not going to get it. Like if I try to sell you something that you have no interest in, and I have not really considered you at all for this place, then the technology is not going to pick up at all. Now, there's a third category of thing, which is sort of like when a technology is like imposed on somebody. And so like a good example for this is probably like you know, a breathalyzer for your car or something like this. Like no one wants to have the breathalyzer on their car, but there's a point at which you are mandated it by law because you have parked on too many trees. And whatever that kind of thing, you do have to be much more wary of this sort of stuff for however you impose your whatever neural technologies might actually be imposed on somebody. So, you know, we're very mindful of this in general, I think, as a community, because unlike maybe even other parts of the body, the brain has a special significance that like some things don't. So, you know, you can get a tattoo on your arm, but it's not going to change who you are. But if you knock out part of your memory, then you are a completely different person, essentially. So we've had in the past, like as a society, like done things like frontal lobotomies and this sort of stuff that have been, again, imposed by you know, courts or governments or whatever. And that's like a whole can of worms for like an ethics perspective there. So there's protecting the consumer from things that they think they might want, right? Or society thinks it might want, and trying to like have ethical considerations about how those things, you know, should be handled in general. And then there's the kind of more, you know, consumer part, which is kind of organic, right? If there's like a need for it and it pops up, and then people will get it because they want the thing.
You didn't even know you needed AirPods, and now everybody has AirPods.
Exactly, right? And it's hard to tell what that thing that you couldn't live without once you had it, despite all the made-for-TV ads or whatever. Yeah, smartphones are a good example. Everyone thought that video calling would come, but they still envisioned it as a payphone. If you think of 2000 Space Odyssey. And it's hard to get away from those ideas because you don't see the future until it's there. And then, you know, hindsight is 2020, and you're like, well, of course we got here because we are here. So I don't know if that answers the question a little bit, but it's just that there's a bunch of different considerations, and we're most likely to see in the near future more adoption driven by clinicians, because they have more money for the bigger toys, which might do the things more often and be paid for by insurance companies. Whereas the fNIRS technology, until it finds like a solid consumer application, right, that could take off, it would be hard to see what exactly that would be right now.
I guess to piggyback off of that, I think it definitely has a lot more clear application because it's neuroimaging, it definitely has a lot more clear applications in the clinic. However, I think possibly what I'd personally expect is that we'd see it first in clinics. So we would have to have more of those conversations with clinicians about, okay, so what is it you need us to design from the engineering perspective? Like, how do we make this something that you can or would want to use over the machines that you already know how to use? And as far as implementation in the general public, that's something that I guess that's just something that there has to be a product which they'd be motivated to use. And that can come in the form of like some sort of BCI. I know that AR and VR are things which have been attempted before to varying levels of success. But if we see those continue to develop in the future, then I suspect that fNIRS could very well see implementation in everyday use.
I think in terms of that, like everyday, like commercial usability of fNIRS, I think we as a community like should also explain an approach to the common society, because like I have like heard cases and like I've experienced cases where I say, hey, like for example, I get a participant in an experiment and we are gonna measure your brain activity using functional near infrared spectroscopy, and it's like infrared. Are you going to fry my brain? And like it goes it was this, you know, it has this like prejudice, it creates this prejudice. So we need to like to be able to commercialize, we need to like explain like this is non-invasive and like we're not frying your brain, and like it's like totally harmless, you know, and we need to convey ourselves, I think, better in that case.
So this is just an older story, but there was one IRB for one study just a while back, and the language in the IRB referred to it as near infrared radiation, which is technically true, but did not go over the IRB very well. And it was a very long discussion after that. And like, what do you mean it's radiation? I was like, no, all wavelengths are radiation. And like, no, you can't.
Good. So great answers, and thank you everyone. And I think I will give it back to the organizers.
I'll just start off. Thank you. Thank you to you all. That was amazing. It was really well thought through and lots of really good points. I did post most of what you said on Twitter. So please go to New Conference 2023 and see if you agree with what I summarized. But it was really, I think, gems of ideas and challenges and suggestions, and the future is bright for this field because you're already thinking about things that we have learned through our mistakes. You're thinking about it proactively, so that's really great. A lot of what we were posting today is on social media, so please go, if you can have time, go and look at it. Hashtag View Conference 2023 and repost. I really want to take a few minutes and thank the organizing team. I know many of the speakers thanked David and me and Alex, but there's a whole team behind us. I don't know if Erin is here. Erin Piska and Charlotte DeRose have been the back end of this conference, and Paria Fazem have been the back end of this conference for a long time, getting all the things together. But at the conference, Nicole, if you don't mind just waving, Nicole, Erin, Maria, Manny, also Marissa at the back there. They've been sort of shepherding the whole real-time conference, and I want to thank the tech team as well. We had Simona yesterday, and Mike, is that Mike? Mike today, and this was a huge enterprise because we were trying to get the hybrid and the in-person piece going, and for the most part, it seems to have gone well. I'm getting emails from people all over the world who have been able to attend the talks that they've joined and giving comments. So thank you for everybody for your cooperation and your willingness to be flexible. And I'm going to hand it over to David.
And just a few more comments, excuse me. So also, I'm very grateful to all of you who traveled here from around the world, the speakers and the trainees and other attendees. Really grateful for that. I don't think Swathi and I have any concluding comments. I think, as was said by many at the beginning, this was the start of a discussion. And I really like how Pepe Dan said it. You know, he came all the way here from Japan because he wanted to be at the start of something new. And so this is, I think, the very good beginning of a discussion that we will continue in years to come. And we already heard next summer, we have the MOBI conference in June. And then 1 month later, a short distance away, we have the Neuroergonomics Conference. So I think those will be two great opportunities next year for all of us to get together again and continue this discussion. I also understand their conferences are even years, and so we might consider odd years for a complementary Neuroscience of the Everyday World Conference. So I know we've all met a bunch of new people here, and we found a lot of common interests, and I think we're all going to have many more opportunities in the coming years to meet again and interact. So thank you again, everyone, for your participation.